Welcome to another episode from the Veterinary Medicine Digest. Consider the bizarre reality of drug development for just a second.
Oh, it's a wild space to work in, definitely.
Right, like you have this biological molecule that when you inject it systemically into a human being, it causes this profound, just agonizing full-body pain.
Right, so bad that they have to immediately abort the clinical trial.
Exactly. It makes even like the lightest touch feel like a burning iron. But then, and this is the crazy part, you take that exact same molecule, you formulate it into an eye drop, and it miraculously heals these previously incurable, blinding corneal ulcers.
Yeah, just regenerating dying nerves right there before our eyes. It is honestly one of the most striking physiological paradoxes in modern pharmacology.
It really is.
And, the molecule you're talking about is nerve growth factor, or NGF. It's this protein that acts as a profound life giver in one context, but then it's the ultimate architect of chronic debilitating pain in another.
And that paradox, that's basically the foundation for our deep dive today.
Absolutely.
So whether you're a veterinary professional who's, constantly managing geriatric patients, or a pharmacologist fascinated by drug delivery, or just someone who wants to understand the bleeding edge of chronic pain management, we are unpacking the entire biological life cycle of NGF today.
It's quite a journey, too.
It is. We're tracing it from its initial discovery back in the mid-20th century through those catastrophic failures and, the miraculous successes in human medicine to figure out exactly how veterinary medicine basically hijacked this pathway.
Which perfectly sets up the main event of today's deep dive.
Right. We're building up to the newest frontier in veterinary osteoarthritis management. We're looking at the evaluation of bedinvetmab.
Which is such a massive leap forward.
It's huge. It's a canonized monoclonal antibody engineered to neutralize this entire pain pathway for 3 solid months with just a single injection.
But, to really appreciate the gravity of a quarterly injection, a drug that alters the peripheral nervous system for 90 whole days, we kind of have to start at the molecular ground floor.
Yeah, let's lay that foundation.
Because the story of NGF, it doesn't actually begin with pain. It begins with life.
Right. Fetal development.
Exactly. When we look back at the developmental biology sources we have, NGF was literally the very first neurotrophin ever discovered.
Wow, the first one.
Yeah. And during fetal development, the nervous system is essentially this chaotic, overpopulated frontier. You have millions of these embryonic neurons extending their axons outward, just blindly searching for target tissues.
Like muscles, organs, skin.
Exactly, tissues to innervate.
It's basically a massive biological land grab.
That is the perfect way to describe it. The neurons are racing to establish connections, but the target tissues are, they're stingy.
Right.
They only secrete a highly restricted, localized amount of nerve growth factor. So the neuron reaches the target tissue, absorbs that NGF, and that NGF acts as a survival signal.
So if it secures the NGF, it lives.
Yep. It lives, it differentiates, and it becomes a prominent part of the peripheral nervous system.
But what about the ones that don't make it? The alternative is pretty brutal.
Brutal but necessary, yeah. The neurons that fail to reach the target or, just fail to secure enough of that limited NGF pool, they immediately undergo apoptosis.
Programmed cell death.
Exactly. The developing body uses NGF to just ruthlessly prune the nervous system. It ensures that only the most efficient, properly wired sympathetic and sensory neurons actually survive.
So in that fetal environment, NGF is literally the absolute gatekeeper of cellular life.
It is. But development eventually ends, right?
Right. And we are primarily dealing with adult veterinary patients, typically older dogs suffering from degenerative joint disease.
And that's where the story pivots, because the sources highlight that in adult mammals, the role of NGF undergoes this drastic, almost sinister transformation.
It's total flip.
Yeah, because the nervous system is fully wired now. The requirement for a continuous survival factor just drops off. And NGF is repurposed by the body as a primary mediator of nociception.
It becomes the molecular herald of tissue damage.
That transition is so stark. In a mature animal, NGF expression in healthy tissue is practically negligible. You won't really find it.
But the moment you introduce an injury...
Right, a noxious stimulus, a trauma, a sprained cruciate ligament, or, the chronic cartilage degradation you see in osteoarthritis, the structural and immune cells in that area just wake up.
Like the chondrocytes and synovial fibroblasts.
Exactly. And the local macrophages, they suddenly begin synthesizing and secreting massive quantities of NGF directly into the extracellular space of the joint.
So suddenly the damaged knee joint is just flooded with this protein.
Flooded.
I want to trace the exact mechanism here because how does that chemical flood actually translate into a dog limping?
Well, it comes down to the local sensory neurons.
Oh.
The nociceptors innervating that joint capsule, they have specific receptors just waiting for the signal.
The TRKA receptors, right?
Yes, primarily the high-affinity tropomyosin receptor kinase A TRKA, and also a low-affinity receptor called P75NTR. But TRKA is really the critical engine of this pain pathway.
Okay, so the NGF hits the TRKA receptor, then what?
When the locally secreted NGF encounters the peripheral terminal of that sensory nerve, it docks with the TRKA receptor, and this binding event causes two of these TRKA receptors to dimerize.
We link together.
Exactly. They link up, and that triggers an intracellular phosphorylation cascade. But the crazy thing is, the signaling doesn't just stay at the nerve ending.
Wait, really? Where does it go?
The neuron physically internalizes the entire NGF-TRKA complex. It envelops it in this little vesicle called a signaling endosome.
Which, I mean, if you think about the anatomy, that is a massive logistical challenge for the cell, right?
Huge.
Because the nerve ending in the stifle joint isn't the control center. The control center, the nucleus, is located in the dorsal root ganglion.
The DRG, yep.
And the DRG sits all the way up next to the spinal cord. That is a massive physical distance for a microscopic endosome to travel.
It's an incredible journey. The signaling endosome gets loaded onto these motor proteins called dyneins.
Like cellular freight trains.
Exactly like freight trains. These motors physically drag the complex along the axon's microtubule network. They moved retrogradely so, backward from the knee, up the leg, all the way to the DRG.
And how long does that take?
It can take hours or even days, depending on the length of the nerve.
Oh, wow. So once that freight train finally arrives at the DRG and delivers the complex to the nucleus, what happens?
Well, the manufacturing orders for that entire sensory neuron are rewritten. The transcription factors alter the gene expression, and they massively upregulate the production of pronociceptive neurotransmitters.
Like substance P.
Substance P, exactly. And calcitonin gene-related peptide, or CGRP. It completely changes the chemical output.
So it's shouting pain signals louder.
Yes, but it also alters the structural composition of the neuron's membrane. The nucleus starts pumping out an increased number of sodium channels, like Nav1.8 and calcium channels, and it ships them back down the axon to the nerve endings in the joint.
So the neuron isn't just sending a pain signal, it is structurally modifying itself to become hyperexcitable.
Precisely. The threshold for firing just drops completely.
So now, a dog simply shifting its weight like a mechanical load that should just register as normal touch triggers this massive influx of sodium through all these new channels.
And sends an agonizing pain signal straight to the central nervous system. The nerve has been entirely sensitized by that initial NGF exposure.
That is peripheral sensitization in a nutshell.
It is. But the cascade doesn't even end with the nervous system. The sources detail a secondary parallel mechanism that is equally destructive.
The mast cell loop.
Right, because TRKA receptors aren't exclusive to neurons. They're heavily expressed on the surface of immune cells resident in the connective tissues.
Particularly mast cells.
Yes, and this is where the local environment goes from a localized issue to just a raging, chaotic, inflammatory storm.
So when the NGF released by the damaged cartilage binds to the mast cells,
it triggers rapid degranulation. The mast cell violently expels its contents into the surrounding tissue. We're talking about a flood of histamine, serotonin, bradykinin, prostaglandins, and crucially even more nerve growth factor.
Oh, wow. So it makes its own NGF. The analogy that comes to mind here is like a building's fire suppression system failing spectacularly.
Let's hear it.
So the initial injury is the fire. The damaged chondrocytes releasing NGF act as a blaring fire alarm, right? Alerting the nervous system that there's a problem.
Okay, yeah.
But this mast cell interaction means the fire alarm isn't just making noise. It's actively handing out megaphones to every immune cell in the vicinity, instructing them to scream fire while simultaneously throwing gasoline on the flames.
That is a phenomenal way to put it. The localized NGF release triggers systemic immune cells to produce more NGF.
It creates this vicious positive feedback loop.
Exactly, making every adjacent normally quiet nociceptor completely hyperreactive. The inflammatory soup creates an environment of just exquisite sensitivity.
But I mean, we have to look at this evolutionarily, right? The body doesn't build complex, highly demanding feedback loops purely to cause itself suffering. So if NGF causes all this pain, why does the body produce it at sites of inflammation at all? Is it purely maladaptive?
Well, No, not initially. In the
Oh.
context of an acute injury like a sudden fracture or a torn ligament, this massive NGF release and hyperalgesia is intensely adaptive
Oscar.
because the agonizing localized pain is a highly effective behavioral modification tool. It forces the dog to completely offload the injured limb.
Oh, enforcing strict rest.
Exactly. That immobilization prevents further catastrophic tissue damage, and it creates the physical stability that's necessary for acute healing processes to begin.
So the pain is essentially a biological splint.
A biological splint, yes, but that logic completely falls apart in a chronic disease state like osteoarthritis.
Because the initial mechanical insult might have happened years ago, or the cartilage degradation is just a slow, irreversible wearing away.
Right, and the joint tissues just continue to pump out NGF indefinitely.
So the biological splint becomes a permanent physiological prison.
Exactly. The adaptive protective alarm system morphs into a pathological driver of continuous pain. It serves absolutely no healing purpose anymore.
It outlives its usefulness and basically becomes the disease itself.
And chronicity leads to another terrifying consequence documented in the literature: anatomical remodeling,
Wait, remodeling?
like structural changes.
Yeah. If a tissue is bathed in high concentrations of nerve growth factor for months or years, the molecule kind of reverts to its fetal role. It starts acting as a growth factor again.
It actually forces the nerves to change shape.
It does. In advanced models of osteoarthritis and osteosarcoma, researchers actually observe aberrant nerve sprouting.
Oh, wow.
The continuous NGF exposure stimulates the sensory and sympathetic nerve fibers to physically grow. They branch out and they infiltrate deep into the chronically inflamed joint capsule and even into the subchondral bone.
Which normally shouldn't have many nerves, right?
Right. It's normally sparsely innervated,
Yeah.
but these new branches form disorganized, highly sensitive tangles of nerve endings.
Neuromas.
Exactly, neuromas. So not only are the existing nerves hyperreactive, but the body is physically wiring thousands of new alarm systems into a building that is already on fire.
That explains the profound refractory nature of advanced OA pain. You aren't just fighting inflammation anymore. You are fighting a radically altered neuroanatomy.
Which brings us to the great biodelivery paradox.
Right, the eye drop versus the systemic injection.
Yeah, because if scientists in the late 20th century knew that NGF was this potent driver of nerve growth and survival, the logical leap was to use it therapeutically.
The rationale was totally sound based on the in vitro data.
If a patient is suffering from a degenerative neuropathy, their nerves are dying, why not just administer the growth factor to save the nerves?
And they tried. In the 1990s and early 2000s, massive pharmaceutical capital was deployed to initiate clinical trials using recombinant human NGF, or rhNGF.
For humans with severe nerve damage.
Yes, specifically severe diabetic polyneuropathy and HIV-related peripheral neuropathy. They administered the rhNGF systemically, using repeated cutaneous or intravenous injections.
The idea being that it would circulate in the blood, find the dying nerves in the feet or hands, bind to the TuKA receptors, and initiate that fetal survival cascade to rescue the tissue.
That was the hope. But the reality of systemic administration was an absolute nightmare.
The clinical trials hit a brick wall.
A massive one. Delivering rhNGF systemically proved to be fundamentally algogenic. It induced pain at a scale that researchers hadn't fully anticipated.
Because it wasn't just targeting the dying nerves.
Right, it was circulating systemically, so it was finding and binding to every healthy TuKA receptor throughout the entire body.
It initiated that retrograde signaling cascade and the mast cell loop everywhere, all at once.
Everywhere. Patients developed profound, widespread myalgia. They experienced severe mechanical and thermal hyperalgesia, not just at the injection site, but systemically.
That sounds horrific.
The adverse effects were so intensely dose-limiting and the pain so overwhelming that the therapeutic window just completely slammed shut. The medical community had to face the reality that you simply cannot administer NGF systemically to an adult mammal without causing agonizing pain.
But, and this is where it gets fascinating, the literature offers a caveat to this failure. It highlights the importance of the anatomical compartment.
The eye drop exception.
Exactly. Subcutaneous NGF is a disaster, yet a topical formulation of recombinant human NGF, a drug called Senogermin, navigated the FDA approval process successfully.
And is currently used to treat neurotrophic keratitis.
Which is a degenerative disease causing those severe, non-healing corneal ulcers we mentioned at the start.
Right. And the success of Senogermin lies entirely in the unique anatomy of the eye. The ocular surface is a highly privileged, largely isolated compartment.
So when you apply the NGF topically to the cornea, it directly contacts the dense network of damaged corneal nerves.
Yes. It binds to local TRKA receptors, initiates the survival and growth cascades, and effectively heals the ulcer. But crucially, the topical application bypasses significant systemic absorption.
So it doesn't get into the bloodstream.
Barely any. The concentration of NGF that makes it into the systemic circulation is negligible. It completely avoids the widespread myalgia seen in the subcutaneous trials.
It acts locally without setting off the systemic alarms.
Exact.
But even more incredible is what happens to that topical NGF after it hits the eye. Because the sources point out, it doesn't just pool on the cornea. The local biodelivery pathways are incredibly complex.
They are. The topical NGF utilizes transconjunctival and transscleral pathways to penetrate deep into the posterior segment of the eye.
And it gets taken up by the retinal ganglion cells.
Yes. And from there, it demonstrates the exact axonal transport mechanisms we discussed earlier. The NGF is transported via both anterograde and retrograde mechanisms along the optic nerve,
Bypassing the blood-brain barrier entirely.
completely bypassing it. It's been traced all the way deep into the brain, reaching the primary visual areas and the hypothalamus.
So an eye drop, designed to heal a scratch on the surface of the eye, is actively shuttling a massive protein directly into deep brain structures.
It's a masterclass in exploiting axonal highways for drug delivery.
It really is. But while the eye drop proves NGF can be a localized therapeutic tool, it also cements the harsh reality for joint pain.
Right. Adding NGF to a system is almost always a bad idea unless you're in a highly isolated compartment.
So to treat a systemic, chronic condition like osteoarthritis, veterinary medicine realized they had to reverse the strategy.
Instead of harnessing NGF, they had to hunt it down and neutralize it.
The therapeutic objective flipped from agonism to antagonism.
Exactly. If the excessive NGF in the osteoarthritic joint is the key that unlocks the TRKA receptor to initiate the pain cascade.
The goal is to permanently intercept that key before it ever reaches the lock.
And this paradigm shift birthed the era of anti-NGF monoclonal antibodies in veterinary medicine, pioneered, of course, by the development of bedinvetmab.
Let's break down the mechanics of bedinvetmab, because it's not a chemical compound synthesized in a vat, right?
No, not at all. It is a fully canonized monoclonal antibody, a massive complex protein structure engineered to circulate in the dog's extracellular space.
And its sole biological purpose is to bind with high affinity to free circulating nerve growth factor.
Right. And by binding to the free ligand rather than blocking the receptor itself, bedinvetmab creates a massive steric hindrance.
It physically gets in the way.
Yeah, the NGF molecule is physically engulfed by the antibody. It changes its three-dimensional conformation so drastically that it can no longer fit into the binding pocket of the TGA or P75NTR receptor.
The signaling cascade is just silenced at the source. The nociceptor never receives the message that the joint is damaged.
Exactly.
Now, this all sounds incredibly elegant, but I have to push back a little here from a practical clinical standpoint.
Okay, go ahead.
The veterinary community already had a weapon against arthritis.
Yeah.
We've relied on non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen, meloxicam, daracoxib, for decades.
Sure, they're the standard of care.
They're cheap, they're widely available, and they effectively inhibit the cyclooxygenase pathways to reduce prostaglandin synthesis. So if we have a drug that works, why reinvent the wheel? Why did the industry spend billions developing a massive, complex protein therapy just to manage a limp?
It's a fair question, but if you're a clinician, you know the reality. The reality of chronic NSAID administration in geriatric canine populations is just fraught with compromise.
Because of the side effects.
Right. NSAIDs are incredibly effective anti-inflammatories, but they operate with a definitive physiological ceiling. More importantly, prostaglandins aren't just inflammatory mediators, they are constitutive homeostatic molecules.
They do other important jobs in the body.
Essential jobs. They're required to maintain the protective mucosal barrier in the gastrointestinal tract and to regulate renal blood flow.
Right, so if you suppress prostaglandins globally to stop a knee from hurting, you simultaneously strip the stomach lining of its defense against gastric acid.
And you compromise the kidney's ability to auto-regulate during periods of dehydration or stress.
So managing a 12-year-old lab with severe osteoarthritis, a dog that likely has concurrent subclinical renal disease or a sensitive GI tract, it becomes a terrifying balancing act.
You are constantly weighing the benefit of pain relief against the very real risk of inducing a perforated gastric ulcer or precipitating acute kidney injury.
And the field trial data comparing these two modalities makes this risk discrepancy glaringly obvious.
Oh, absolutely. Look at the specific randomized field trial that pitted monthly bedinvetmab injections directly against daily oral meloxicam.
Okay, let's look at the numbers.
They tracked 101 osteoarthritic dogs. In the meloxicam cohort, there were 17 documented adverse events.
17 out of roughly 50 dogs.
Yep. Predominantly gastrointestinal disruptions, vomiting, diarrhea, inappetence.
In the bedinvetmab cohort.
Only 4.
Wow, that's a huge difference.
And that differential intolerability is not an accident. It is the direct result of fundamentally different pharmacokinetic pathways. NSAIDs are small molecule drugs. When a dog swallows an NSA, it must be absorbed through the gut, subjected to first-pass metabolism in the liver.
Via the cytochrome P450 enzyme system, right?
Exactly. Distributed systemically, and finally filtered and excreted by the kidneys. Both the liver and the kidneys bear a significant metabolic burden to process and clear the drug.
But a monoclonal antibody bypasses that entire metabolic gauntlet.
Entirely. Bedinvetmab is essentially a native canine immunoglobulin G protein. When you inject it subcutaneously, it's absorbed slowly through the lymphatic system and enters the central circulation, just mixing with the dog's endogenous pool of antibodies.
So the liver doesn't metabolize it at all.
No, and it is far too large to be filtered by the renal glomeruli.
So how is it cleared then?
It's eliminated through ubiquitous endogenous proteolytic pathways.
Okay, unpack that.
Throughout the body, reticuloendothelial cells naturally engulf circulating proteins and break them down via intracellular proteases. The massive bedinvetmab molecule is systematically dismantled into its constituent individual amino acids.
Oh, so it just gets broken down into basic building blocks.
Exactly. These amino acids aren't toxic waste products. The dog's body simply recycles them into new endogenous proteins or oxidizes them for energy. The metabolic footprint is practically zero.
It's the ultimate biological recycling program.
It really is.
But wait, that raises an immediate mechanical question. If every cell in the body is constantly drinking in surrounding fluid and breaking down proteins, why isn't the bedinvetmab destroyed within hours of the injection? Like, how does a single dose survive in this hostile proteolytic environment long enough to provide a full month of continuous analgesia?
That is the genius of it. The secret to its longevity lies in a brilliant piece of evolutionary engineering called the neonatal FC receptor.
The FcRn receptor.
Yes. The endothelial cells lining the blood vessels are constantly undergoing penocytosis. They drink in small gulps of plasma, capturing whatever proteins happen to be circulating, including bedinvetmab.
Okay.
This plasma is pulled into the cell and enclosed in an intracellular compartment called an endosome.
And as that endosome matures, its internal environment becomes highly acidic, right? Which usually signals the cell to deploy destructive enzymes to tear the proteins apart.
Precisely. The drop in pH is the trigger for destruction. But, and here's the magic, that acidic drop also triggers a specific conformational change in the FcRn receptor located on the wall of that endosome.
Oh, interesting.
In this acidic environment, the FcRn receptor binds tightly to the FCC portion of the bedinvetmab molecule, and this binding acts as an impenetrable molecular shield.
So while other random proteins trapped in the endosome are ruthlessly degraded by the acidic enzymes,
the bedinvetmab bound to the FcRn receptor is protected.
the receptor acts like a biological life raft.
It does. The endosome then traffics back to the cell surface, merges with the cell membrane, and is exposed to the neutral pH of the blood.
And the pH shift changes the receptor again.
Exactly. The shift back to a neutral pH causes the FcRn receptor to release its grip, depositing the fully intact, functional bedinvetmab molecule right back into systemic circulation.
Wow. So this relentless, continuous cycle of being swallowed, shielded, and regurgitated back into the blood. That's what stretches the terminal elimination half-life of bedinvetmab to an incredible 19.1 days.
That's the exact mechanism. It's what allows a veterinary clinic to replace a daily handful of risky NSAID pills with a single, safe, monthly subcutaneous injection.
And the large-scale clinical trials obviously validated this.
Absolutely. Across massive, double-blind, placebo-controlled, multisite studies in both the U.S. and Europe, bedinvetmab demonstrated profound efficacy.
They use the Canine Brief Pain Inventory for those, right? The CBPI.
Yes, which requires owners to score their dogs on pain severity and how that pain interferes with daily functions like rising, walking, and running.
And the metrics for success were rigid. A dog had to show significant statistical improvement in both severity and interference to be considered a treatment success.
And the data showed that neutralizing the free NGF provided sustained, robust analgesia that translated to vastly improved quality of life scores across a 9-month continuation phase.
The monthly injection worked, and it worked without taxing the liver or kidneys.
Exactly.
But, as revolutionary as this sounds, we cannot tell the story of anti-NGF therapies without addressing the massive dark shadow hanging over this entire drug class.
We absolutely have to talk about it.
Because while the veterinary world has been celebrating this breakthrough, the human pharmaceutical industry experienced a nightmare scenario that almost killed the technology permanently.
The human trials. It is essential context.
Yeah, let's get into it.
So while veterinary medicine was developing canonized antibodies, massive human pharmaceutical conglomerates were pouring billions into their own humanized anti-NGF monoclonal antibodies. The most prominent of these was a drug called tanezumab.
Right, and tanezumab was aimed at treating human patients with severe osteoarthritis of the knee and hip.
Yes. And in 2012, tanezumab was in massive phase 3 clinical trials involving thousands of patients. But suddenly, investigators started observing a horrific, completely unexpected structural joint failure in a subset of the trial participants.
They termed it rapidly progressive osteoarthritis, or RPOA.
Right, and to understand why RPOA is so terrifying, you have to look at normal OA progression. Osteoarthritis is typically an incredibly slow, grinding disease.
Sure. If you take serial radiographs of a human knee over several years, you might see the joint space narrow by, what, a fraction of a millimeter annually?
Exactly. But the patients taking tanezumab weren't following that timeline. In the cases of RPOA, the joint space narrowing aggressively accelerated, exceeding 1 millimeter of loss per year.
That's massive.
The cartilage was rapidly disintegrating, leading to bone-on-bone contact, subchondral bone collapse, and in many severe cases, forcing the patient into an emergency total joint replacement.
So the drug designed to stop joint pain was seemingly destroying the joints themselves.
Yeah. The FDA reacted immediately and aggressively. They slammed the brakes on the entire class of drugs, imposing strict clinical holds on all anti-NGF development programs across the industry.
They demanded answers.
They did. And when the data analysts dug into the demographics of the patients developing RPOA, they found a glaring epidemiological smoking gun.
The NSAAs.
Yes. The risk of rapid joint collapse skyrocketed in patients who were taking the experimental anti-NGF drug while concurrently taking high doses of traditional NSAIDs.
The concurrent use of NSAIDs was the primary catalyst.
It was. Now, the exact mechanism behind this lethal combination is still debated in the literature, but there are two prevailing hypotheses.
The first is the analgesic arthropathy, or the joint loading hypothesis, right?
Tanezumab provided such profound, unprecedented pain relief that the human patients essentially felt cured. They had been sedentary for years due to pain, and suddenly they felt no pain at all.
So they dramatically increased their physical activity. Walking miles, jogging, climbing stairs.
Exactly. But their joints were still structurally diseased and fragile. The profound analgesia allowed them to mechanically overload and essentially crush their own osteoarthritic joints because the protective warning system of pain was entirely silenced.
That makes total sense.
Yeah.
But what's the second hypothesis?
The second hypothesis points to a more insidious pharmacological interaction. NSAIDs don't just stop inflammation, they alter local bone metabolism and can actually inhibit chondrocyte proliferation.
Oh, so the combination of profound NGF blockade plus the cartilage-altering effects of high-dose NSAIDs
created a perfect toxic storm that completely disrupted the joint's ability to maintain its structural integrity under stress.
And even when the FDA eventually allowed the trials to resume, they imposed massive risk evaluation and mitigation strategies, REMS protocols, right?
Yeah, strictly prohibiting NSAA co-administration, mandating frequent MRIs and radiographs to catch bone collapse early. But even with all those guardrails, the RPOA signal persisted.
Ultimately, the risk-benefit ratio for human use was deemed unacceptable. It derailed the widespread approval of tanezumab.
It did.
Which forces us to ask the most glaring, uncomfortable question of this entire deep dive.
I know exactly where you're going with this.
If this specific class of drugs caused human knees and hips to collapse so rapidly that patients required total joint replacements, Why on earth did the veterinary community look at that data and decide it was a good idea to inject a nearly identical mechanism of action into our dogs every single month? Are we just quietly dissolving the joints of our veterinary patients?
It is the most critical question a practitioner or a pet owner can ask. But science is dictated by data. And when we scrutinize the massive data sets emerging from the veterinary field over the last few years, the reality is starkly, fundamentally different from the human experience.
Okay, let's look at the actual post-marketing pharmacovigilance numbers, because millions of dogs have now received this drug outside the controlled bubble of clinical trials.
Globally, over 18 million doses of bedinvetmab have been administered.
18 million, okay.
And out of those 18 million doses injected into the general canine population, the pharmacovigilance databases have recorded a total of 2,404 reported musculoskeletal adverse events.
2,404. Now, when we just look at that raw number, it might sound concerning.
Sure, but run the math. Against 18 million doses, the incidence rate drops to a remarkably low 1.33 events per 10,000 doses.
Wow.
And that figure includes every single reported limp, stiffness, or worsening of arthritis, regardless of whether a veterinarian actually confirmed it was drug-induced or just the natural expected progression of a 14-year-old dog's pre-existing disease.
So the data unequivocally shows that there is no massive wave of catastrophic joint collapse happening in dogs.
None at all. The drug is overwhelmingly safe in the target species. But that epidemiological divergence demands a physiological explanation, right?
Right. Why do human joints crumble under anti-NGF therapy while canine joints remain structurally sound?
The primary hypothesis hinges on fundamental biomechanics. Humans are bipedal obligates. Our entire upper body weight, gravity, and the kinetic force of walking are driven entirely down a vertical axis directly into two joints, the hips and the knees.
The sheer compressive force on a human knee is immense.
Contrast that with the canine biomechanical model. Dogs are quadrupedal. Their body weight is distributed across 4 limbs. And importantly, the distribution is not equal.
Oh, right. They carry roughly 60% of their body weight on the forelimbs, the shoulders and elbows.
Exactly, and only 40% on the hind limbs.
Yeah.
This 4-point suspension system dissipates mechanical stress much more efficiently.
So even if a dog experiences profound analgesia and dramatically increases its activity level,
the mechanical load is distributed across a wider anatomical base, potentially preventing the localized catastrophic crushing seen in bipedal human knees.
that makes total sense physically. But beyond the physics, there's also a massive difference in how the drug is clinically managed, right?
A huge difference. The human trials were plagued by patients self-medicating with over-the-counter NSAIDs like ibuprofen or naproxen to supplement the trial drug.
Oh, right. Whereas in veterinary medicine, the concurrent use of NSAIDs with bedinvetmab is strictly warned against on the label, precisely because of the human RPOA data.
Exactly. Veterinarians control the prescribing. There is no over-the-counter NSAID market for dogs, which prevents the exact pharmacological cocktail that triggered the human joint collapse.
So the clinical guardrails in veterinary medicine are much stronger, and the canine anatomy is more forgiving.
The culmination of this data paints a clear picture. Respecting the potency of the NGF pathway is mandatory, but neutralizing it in the dog using a targeted monoclonal antibody is a highly safe and profoundly effective strategy.
Which brings us to the bleeding edge of the science, the core of the new main1.pdf article we are analyzing today. Veterinary medicine successfully deployed a monthly anti-NGF injection that safely bypasses the liver and kidneys. But in pharmacology, the moment you prove a delivery system works, the immediate next objective is to stretch its duration.
Always. If you can make a drug last 30 days, can you make it last 90?
And that brings us to azenovetmab and the 3-month horizon.
Azenovetmab represents the next generation of this therapeutic class. Like its predecessor, it is a canonized monoclonal antibody designed to bind free NGF.
The mechanism of action is identical.
Identical, but the massive structural and pharmacokinetic differentiator is its extended half-life. Azenovetmab is engineered to be administered via subcutaneous injection only once every 3 months, utilizing a highly optimized dosing range of 0.05 to 0.1 milligrams per kilogram.
4 injections a year instead of 12? The clinical implications of that shift are staggering.
Huge for compliance.
Right. For a highly reactive dog that requires sedation just to walk into a clinic, or for a pet owner with limited mobility, restricted finances, or simply poor compliance with medication schedules. A quarterly injection completely changes the landscape of chronic pain management.
It really does. But with extended duration comes extended risk.
Obviously. If a dog has a severe adverse reaction to a daily pill, the owner stops giving the pill and the drug washes out of the system in 24 hours.
But if a dog has a severe adverse reaction to a monoclonal antibody engineered to survive in the bloodstream for a quarter of a year, you cannot easily extract it.
That drug is locked in.
It's locked in. Therefore, the pre-approval laboratory safety protocols for bedinvetmab had to be ruthlessly thorough.
And the developers were acutely aware of the stakes. Before any clinical field trials could commence, they executed 3 highly controlled, integrated laboratory safety studies utilizing healthy beagle dogs.
Right. And the goal was to push the drug far beyond its intended clinical parameters to establish definitive safety margins.
Let's examine the first major protocol, the target animal safety evaluation. They needed to validate the intended 3-month dosing interval, but they couldn't just test the normal dose.
No. They had to test an exaggerated dose to see where the toxicity threshold began. They established a protocol where the beagles were injected once every 3 months for a total of 3 doses, representing 9 months of continuous therapy.
Okay.
However, instead of administering the high end of the clinical dose, which is 0.1 milligrams per kilogram, they pushed it to 0.6 milligrams per kilogram. They were injecting 6 times the intended therapeutic dose.
6 times the dose for 9 months.
Yes. And during those 9 months, they subjected these dogs to exhaustive physiological surveillance. Continuous electrocardiograms to ensure cardiac conduction wasn't altered, deep neurological exams, checking proprioception, reflexes, cranial nerve function.
I read they brought in veterinary ophthalmologists, too, to examine the retinas and corneas, ensuring the blockade of NGF wasn't causing degenerative ocular changes.
They did. And most importantly, given the historical specter of the human RPOA data, they implemented a rigorous radiographic surveillance program.
Serial high-resolution radiographs of the appendicular skeleton.
Exactly. The stifles, hips, elbows, and shoulders. They were searching for any. They did. And this specific scenario was the genesis of the extreme dosing margin evaluation. In this protocol, they completely abandoned the 3-month interval. They took this long-acting azenovetmab and injected it into the beagles monthly for 4 consecutive months.
But they didn't just alter the frequency.
No, they exponentially increased the volume. They administered an astonishing 120 times multiple of the clinical dose, injecting 12 milligrams per kilogram every 30 days.
120 times the dose, given 3 times as frequently as it's designed for. That is a massive volume of protein being dumped into the system.
It is.
I mean, if you gave a dog 120 times the clinical dose of an NSAID, say a handful of carprofen, the physiological response would be rapid and fatal.
Oh, without a doubt. The massive inhibition of prostaglandins would cause acute total renal failure, catastrophic gastrointestinal ulceration, and sepsis. The dog wouldn't survive the week.
But with this drug.
The contrast highlights the incredible therapeutic index of monoclonal antibodies. Even when subjected to this absurd 120x monthly overdose, the azenovetmab was still remarkably well tolerated by the beagles.
Wait, really? No organ failure?
No organ failure, no systemic toxicity, and no death. Because the antibody is highly specific, it simply saturated every single molecule of free NGF in the body, and the massive excess antibody just circulated harmlessly in the plasma until it was slowly broken down by endogenous proteases.
Because it cannot cause off-target chemical toxicity. It simply doesn't interact with any other receptor or organ system.
Precisely. The physiological resilience is incredible.
But wait, while the liver and kidneys are safe, we established earlier that NGF heavily interacts with the immune system.
The mast cell loop, the TRK receptors on macrophages, yes.
So if you introduce azenovetmab and completely neutralize all free NGF in the body for months on end, do you accidentally cripple the immune system? Do you induce a state of profound immunosuppression, leaving the dog vulnerable to opportunistic infections?
That theoretical risk mandated a highly specific functional immunological evaluation. To prove that chronic NGF blockade doesn't suppress the immune system, the developers conducted a T-cell-dependent antibody response, or a TDAR test.
And a TDR test doesn't just count white blood cells. It forces the immune system to actively perform a complex task to prove it's still working. How exactly did they run this test on the beagles?
They took the dogs that were under the influence of the anti-NGF therapy and injected them with a novel, harmless foreign protein, specifically keyhole limpet hemocyanin, or KLH.
Okay, so because the dog's immune system has never encountered KLH before, it has to build a defense from scratch.
Exactly. It requires deep cellular communication. The antigen-presenting cells have to find the KLH, process it, and present it to the T cells. The T cells then have to chemically communicate with the B cells,
instructing the B cells to proliferate, differentiate into plasma cells, and manufacture entirely new antibodies specifically tailored to neutralize the KLH.
It tests the entire communication chain of the adaptive immune system. If the bedinvetmab was causing immunosuppression, that delicate chain of communication would break down and the dog would fail to produce a significant volume of anti-KLH antibodies.
And the results?
The results of the TDR death were definitive. The dogs treated with long-term bedinvetmab mounted robust, highly effective antibody titers against the KLH antigen that were statistically indistinguishable from the control group.
Wow. So the complete long-term blockade of nerve growth factor did not impair the complex immune surveillance or response mechanisms.
Not at all.
Speaking of the immune system producing antibodies, we have to talk about the dog's immune response to the drug itself, because bedinvetmab is a massive, complex protein structure. Even though it is canonized engineered to look as close to native dog proteins as possible, it is still synthesized in a laboratory.
Right. There is always a risk that the dog's immune system will recognize this injected drug as a foreign invader and start manufacturing anti-drug antibodies, or ADAs, to destroy it.
Immunogenicity is a constant hurdle in biologics development.
It is. If a patient develops high levels of neutralizing ADAs, those endogenous antibodies will bind to the bedinvetmab, clear it from the bloodstream prematurely, and render the therapy completely ineffective. Furthermore, massive ADA formation can theoretically lead to immune complex deposition diseases or acute anaphylaxis.
So they rigorously tracked the ADA formation rates across all these laboratory studies. What were the numbers?
The incidence of immunogenicity was highly encouraging. In the 6X target safety evaluation, the ADA rate was only 4.2%.
Very low.
In the extreme 120x monthly dosing evaluation, it rose slightly to 8.3%. And in the immunomodulation cohort, it was 6.25%.
So across the board, fewer than 10% of the dogs recognized the drug as foreign.
Correct. The canonization process was highly successful. And more importantly, in that small single-digit percentage of dogs that did develop ADAs, there was absolutely no negative safety impact.
No anaphylaxis.
None of the dogs experienced anaphylaxis, serum sickness, or adverse systemic immune reactions. The worst-case scenario for those specific dogs is simply a reduction in the drug's half-life and long-term efficacy, but their physiological safety was never compromised.
Okay, I am tracking the data logically here. The clinical exams were clean, the joints survived the massive overdoses, the immune system functioned perfectly under the TDR test, and the ADA rates were negligible. It paints a picture of near-perfect safety.
It really does.
But when I was reviewing the highly granular histopathology data from the main 11.pdf source, I found a detail buried in the microscopic evaluations that initially seemed alarming.
I think I know what you're referring to.
The pathologist noted that in a few dogs they observed minimal neuronal atrophy in the sympathetic ganglia, and they described it as having an increased glial cell density. If I am a veterinarian reading that a new drug causes neuronal atrophy, the physical shrinking or wasting away of nerve cells, my immediate instinct is to reject the drug as neurotoxic. How can neuronal atrophy be classified as safe and well tolerated?
It's a really astute observation, and it highlights the necessity of understanding the difference between a toxic event and an expected pharmacological mechanism. To alleviate that alarm, we have to connect this specific canine histopathology directly back to the preclinical primate safety data generated during the development of the human drug, tanzumab.
Oh, interesting. What exactly did the primate data reveal?
During the safety evaluations for tanzumab, researchers administered the humanized anti-NGF to cynomolgus monkeys. When they performed the post-mortem histopathology on those monkeys, they found the exact same microscopic phenomenon.
Minimal neuronal atrophy in the sympathetic ganglia,
paired with what appeared to be an increase in the density of surrounding glial cells. Initially, the FDA and researchers were highly concerned about potential neurotoxicity. But upon exhaustive investigation, the primate data proved 3 critical points that completely changed the context of the finding.
Walk me through those 3 points, because they're crucial to understanding the canine data.
First, the researchers proved that the atrophy was strictly non-progressive. The neuronal shrinkage began roughly 2 weeks after the initial anti-NGF dose, reached its maximum structural extent by the 1-month mark, and then completely stabilized.
So it didn't just keep shrinking until the cell died.
Exactly. Continued administration of the drug for months did not cause the neurons to shrink further, nor did it induce neuronal death or apoptosis. It hit a structural plateau.
Okay, a non-progressive change is inherently less threatening than a degenerative one. What was the second point?
The change was entirely reversible. When the researchers stopped administering the tanezumab and allowed the NGF blockade to wash out of the system, the free NGF returned to the ganglia. Within weeks, the sympathetic neurons re-engaged with the growth factor, reversed the atrophy, and returned to their normal baseline morphological size and volume.
That's fascinating. And the third point, which I imagine is the most clinically relevant.
The atrophy was completely asymptomatic. Despite the microscopic changes in the sympathetic ganglia, the cynomolgus monkeys exhibited zero clinical signs of autonomic nervous system dysfunction.
Really? No changes in heart rate or anything?
Their resting heart rates were normal, their blood pressure regulation was intact, their pupillary responses were flawless, and their gastrointestinal motility was unaffected. The sympathetic nervous system continued to function perfectly despite the slight reduction in neuronal cell volume.
So synthesizing those 3 points, it's not toxicity, it's a predictable biological consequence. We established at the beginning of this deep dive that NGF acts as a maintenance and survival factor for sympathetic neurons. If you intentionally introduce a drug whose sole purpose is to temporarily remove that maintenance factor, it makes complete biological sense that those specific neurons would undergo a mild, temporary, and harmless morphological shrinkage.
Precisely. They aren't dying, they are just downregulating their volume in the absence of the growth signal.
It is an expected, non-adverse, microscopic artifact directly related to the drug doing exactly what it was designed to do.
Yes. Furthermore, the increased glial cell density is largely an optical illusion.
Wait, an illusion?
Yeah. The supporting glial cells didn't actually multiply. Because the central neuronal cell bodies shrank in size, the surrounding glial cells simply collapsed inward, making them appear closer together under the microscope.
Oh, it's like letting half the air out of a large balloon. The rubber skin suddenly looks thicker and denser, but you didn't actually add any new rubber, you just reduced the internal volume.
That is perfect visualization of the histological change. And to put the bedinvetmab data into clinical perspective, during the massive target animal safety study in the beagles, the pathologists evaluated 168 separate sympathetic ganglia under the microscope across all the test groups.
Okay.
This expected minimal neuronal atrophy was only observed in exactly 2 ganglia taken from 2 dogs in the high-dose 6X group.
2 instances out of 168 evaluated tissues, and only in 6 times the clinical dose.
Exactly.
When you contextualize it with the primate data, proving it's non-progressive, completely reversible, and totally asymptomatic, that microscopic detail goes from terrifying to incredibly reassuring. It proves that the regulatory safety evaluations for these new veterinary biologics are so intensely granular that they are identifying and explaining harmless, reversible cellular illusions.
It demonstrates a profound depth of pharmacological understanding. We are no longer just guessing at mechanisms. We are observing the precise cellular consequences of targeted molecular therapies and proving their safety at the microscopic level.
Which brings us to a massive overarching synthesis of the incredible biological journey we've mapped out today. We started in the 1950s with the discovery of nerve growth factor, a foundational protein that acts as the ruthless gatekeeper of life and death for the developing fetal nervous system.
It's been quite the ride.
We explored how that exact same molecule flips its physiological script in the adult dog. It becomes the molecular herald of osteoarthritis, secreted by inflamed, degrading joints binding to TKA receptors and hijacking the dyne and motor transport system to rewrite the genetic code of the dorsal root ganglion.
And we saw how it establishes that mast cell feedback loop, handing out inflammatory megaphones to the immune system, and eventually driving physical, aberrant nerve sprouting that transforms acute protective pain into a chronic, debilitating disease state.
We analyzed the catastrophic failure of the human trials, proving that you cannot simply inject recombinant NGF systemically without inducing agonizing full-body hyperalgesia. And we marveled at the biodelivery paradox, where that same algogenic molecule can miraculously heal a dying cornea simply by leveraging the isolated, privileged compartment of the ocular surface.
Then we tracked the veterinary paradigm shift from adding NGF to neutralizing it. We examined how bedinvetmab fundamentally changed the clinical approach to canine osteoarthritis.
By utilizing the elegant, continuous recycling mechanism of the FcRn receptor, veterinary pharmacology evolved away from relying on daily NSAID pills that forced the liver and kidneys into a dangerous metabolic balancing act, moving toward the safety and compliance of a targeted monthly injection.
We contrasted the devastating, rapidly progressive osteoarthritis seen in the human tanezumab trials with the overwhelming post-marketing safety data in dogs, driven by quadrupedal biomechanics and strict veterinary control.
And finally, we arrived at the new horizon defined by vetmab. We reviewed the exhaustive preclinical Beagle data, proving that it is possible to formulate a canonized monoclonal antibody that safely and effectively neutralizes the NGF pain pathway for 3 solid months.
Surviving massive 120x extreme overdoses, maintaining the integrity of the adaptive immune system through TDAR testing, and generating negligible ADA responses, all while confirming that microscopic sympathetic changes are simply harmless expected pharmacological artifacts.
It is a profound, monumental shift in how veterinary medicine conceptualizes and manages chronic disease, prioritizing both the absolute efficacy of the molecular blockade and the practical, real-world realities of drug delivery and owner compliance. And that leads me to a final, highly provocative thought for you, the listener, to mull over as we wrap up this deep dive.
Let's hear it.
We have spent this entire discussion obsessively focused on osteoarthritis and the peripheral pain pathway. But if the biotechnology now exists to engineer a canonized monoclonal antibody that can safely, effectively, and precisely neutralize a specific systemic target for a quarter of a year with a single subcutaneous injection, what other chronic, devastating veterinary diseases are suddenly right for this exact same quarterly delivery model?
It is the most exciting question in veterinary pharmacology today. The molecular platform has been proven. The technology exists to map, sequence, and build neutralizing antibodies against almost any soluble physiological target in the mammalian body.
If we can overcome the FcRn receptor degradation for 90 days to stop joint pain, imagine applying that adherence-boosting power to the daily pill struggles that plague veterinary clients. Could we engineer a quarterly monoclonal antibody that permanently binds and neutralizes circulating thyroid hormones, revolutionizing the treatment of feline hyperthyroidism and eliminating the need for twice-daily oral methimazole in fractious cats?
Or could we design a 3-month injection targeting interleukin-31 to completely suppress the agonizing itch of canine atopic dermatitis, replacing the monthly administration of vetmab?
Or could we look deeper, targeting the specific inflammatory cytokines and fibrotic pathways that drive the relentless progression of chronic kidney disease, fundamentally altering the lifespan of our geriatric patients? The biological ceiling defined by how fast the liver and kidneys break down a small molecule pill has been shattered. The 3-month therapeutic horizon is no longer theoretical. It is here, and neutralizing osteoarthritis pain is clearly just the beginning of this revolution. Thank you for listening. The titles for the reference papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.